So let me just. All right. Thank you for coming, guys. And can you hear me well in the Meet land, Meet zone, Zoom land? Anyone over there?
Yeah, they can hear you.
Yes, we can hear you.
All right. So today like this is the third part of our mechanical ventilation lecture. We talked in the first. We talked about the first part about like the pressure scaler, and the second part about the flow and pressure scaler as well. And today we'll go over the ventilator definition, which is very important, and we'll say what is the ventilator definition. However, the first two slides will be just for a quick review for what we have mentioned in the first two slides. So if Mahmoud and Kareem stop playing with their phones, then so all right. So we'll go with the first thing, that the pressure scaler. The pressure scaler, that usually what we said is like when you look at the waves, it's very important. Like in cardiology, like you just don't look at the EKG and go. Is that right? We look at the EKG and try to interpret each part of that tracing to know exactly how is the heart working. And it's the same in here. We need to look at each part of the waves to see like what's the lung mechanics, what's going on in the lung. And we talked last time that this is the peak pressure, the positive inspiratory pressure. And when we do inspiratory hold, that's the plateau pressure, which is there's no flow going. It's just like the pressure that keeping the airway open and the alveoli open without any flow moving. And then we said that at the end of expiration, that the pressure left inside the alveoli, that's what we call the positive end expiratory pressure. And we said the difference between the peak and plateau, it's the resistance, and that depends a lot on the flow. So that's why we said to do it like easier, you can just change your flow in the machine and make it 60, and then your resistance will be just the peak minus the plateau pressure. And the compliance is the difference between the plateau and the peak pressure. And with the and we have the tidal volume as well, the variation in tidal volume. So that's what we, when we look at the pressure without doing any calculation, when we look at the pressure scaler, you can judge if there's like a high resistance or a high compliance or both going together. And we'll talk about that more today. So this is the inspiratory time, and this is the expiratory time. The inspiratory time divided to the inspiratory flow time, which there's a continuous flow going on. And in here, I'm the one who posed the mechanical ventilation, and that's why we have no flow. That's an inspiratory pause. And we said airway resistance is the peak minus the plateau divided by flow, and normal should be less than 10. And we mentioned exactly how we will get benefit from knowing that during when the patient on mechanical ventilation. And pulmonary compliance, and it's the delta volume divided by plateau minus PEEP, and that's the static compliance, not the dynamic compliance. So, and as we said, you use the resistance in patient with COPD who got intubated on mechanical ventilation. You check it in the first day, you do your intervention, and then you recheck it again to see if there's any improvement clinically and mechanical ventilation wise. Compliance, we always look at it on all patients, pneumonia, ARDS, any patient in mechanical ventilation, that will give you the clue of your mechanical, your lung mechanics. And then in the second lecture, we talked about the flow, and we said we have multiple different type of flow. We have like constant square flow, which is this one, and we have the sinusoidal flow, and we said we have the decelerating flow, and we have the accelerating flow. Usually, we said we use the constant or decelerating flow, and we said normally all of us, when we talked at the first lecture in the way how we breathe, like the flow at the beginning, because of the big difference in pressure between the atmospheric pressure and the pressure inside my lung, the flow will come fast in, and then when the pressure equalizes, it starts slowing down. So it's usually the physiological flow is decelerating flow. That's why the patient feel comfortable more in the decelerating flow. Okay. All right. That's the quick review of the previous topics or previous sessions. So today we'll talk about the definition of mechanical ventilation. So, like for a quick example, I will go with Abu Zaid. So BRVC, is that a volume control or pressure control, or what's that exactly? PRVC. What does PRVC stand for? So we do it a lot at St. Mary, is that right?
Both combined.
So what BRVC stands for? See, that's okay. That's like, if you don't know, that's a good pressure.
Regulated volume control.
Awesome, good. Pressure regulated volume control. So is that a volume control or a pressure control?
It's I think it's originally pressure control augmented with the volume. I think it has part of they added volume control to
Okay.
augment volume if the patient doesn't.
So if you're gonna pick one, pressure or volume, which one are you gonna pick?
Pressure.
Good. What do you think, guys? Saddam.
Volume.
It's volume control,
Pressure control.
pressure control.
I take it as AVAPs.
Okay, so that's good. Having like different answers, that's how we learn. Is that right?
AVAPs, you have pressure and you have the volume, so the patient will regulate. I mean, BRVC, the mechanism is like AVAPs.
Good. So mechanism like AVAP, and you're right. But the thing is it pressure control, volume control? And we'll go over it. The other question that we ask ourselves, like, oh, I can ask you now, can you please put this patient on volume control with our, like now, our Bella Vista mechanical ventilation, and you will just choose VC, is that right? That's what it says, VC. And you just click on it and you put the patient on VC and you think it's a volume control. And that's it. Is that right? So as someone who's like, that's not his specialty, is taking care of mechanical ventilation and like taking care of a critical care patient, I will accept it, like just put it in VC and like the respiratory therapist will take care of it. But as you are an intensivist, you should know more in depth about what you are doing in the mechanical ventilation. Okay, so that's why those names, like, there is multiple brands, is that right? Like you might go to more, like next year work in a different hospital, you will have a different brand. Different like different country, you will have a different brand, and you will say, oh, this is a VC plus. Oh, what's this? This is a BRVC. Is it difference between VC plus and this is VC? This is pressure control, adaptive flow, and all of these three are the same, but a lot of different names. Is that right? So that's why we should not go with these names. We should go with the definition of exactly what's the relationship between you as the operator and the mechanical ventilation and the patient. What's the relation? What I can set in the machine, what the machine can do for the patient, and how the patient will respond to this machine. That's what you should know, not just like, oh, it's VC, BVC, and stuff like that. Okay. So in the old way, like when teaching mechanical ventilation, we just say, okay, so how is the breath is delivered? Are we delivering the breath according like just volume? So we are controlling the volume, or its pressure. Those are the two ways that you will deliver the breath. You are controlling the pressure or you are controlling the volume. Okay. And when the inspiration or when is the breath will start, when the valve will open inside the machine and say start inspiration. That usually it could be like connected with flow or triggered by the pressure. That's what we say, trigger. What does that mean? So I said the machine, hey, if the pressure goes down by 2 less than the baseline, assist this breath or start this breath. Or I say if the flow changed from this to this, start this breath. So if the patient start using his muscles, start trying to use his muscles, the flow or the pressure will change. The flow and the pressure will change, but I'm the one who told the machine which one that should look at to start the breath. Okay. And we'll go over this like in details.
Yeah, time is a trigger by itself.
What was that? Sorry
for interruption. Is time as one of the triggers that we consider as well?
So
The time, he said.
yeah. So the time, usually like you set the respiratory rate. So that's if you don't trigger, then the machine will go with the mandatory rate. So it will just, the machine will trigger, but we don't say it's a time trigger. So if the patient doesn't trigger, so you have a set rate that the machine will do. But I will go over more like how the triggers and how the tag itself. So cycling, when should the inspiration stop and the expiratory valve open and patients start like to exhale? That could be time. So if after this specific time of inspiration and expiration, that I set the respiratory rate and I set everything, and the machine will say, okay, after a 1 seconds, the expiratory valve will open. That's it. Or after I deliver specific volume, or if like which is like or flow. So those are the three things that we mainly stop the, and we will talk more about it, guys, and mainly stop the cycle. Or sometimes the patient, he's the control of this. So the time flow and volume, that's like we can set it up, or the patient, he's the one who control when the machine should stop. And we'll see how can we know that, okay? And there's two types of breath. There's mandatory breath and spontaneous breath. All right, so that's the old way how the the mechanical ventilation was like taught, and like, hey, this is it and done. That's it. But nowadays we talk about what we call the tag, which is the tag. It's the definition of your mechanical ventilation. It's the definition of the relation between you, the machine, and the patient. All right. So, and we group it in three things. All right. So, three things. The control variable. What does that mean? As an operator, what I'm controlling? Am I controlling the pressure or I'm controlling the volume? All right. So, those are the two control. There is nothing else. I'm controlling the pressure or controlling the volume. And then there is the breath sequence. What does that mean? Does all the breath are mandatory breath, or some of them are mandatory and some of them are spontaneous, or all of the breath are spontaneous? Okay, so those are the main three types. There's no other type: continuous mandatory breath, continuous spontaneous breath, or we have intermittent mandatory breath. Means that there's both together. Okay, and we'll talk more in depth. The last thing, which is the targeting scheme. What does that mean? So if it's pressure control, if it's or volume control, so what's the targeting? Means that if this patient in volume control, I'm telling this patient, hey, the volume I want you to deliver is 500, and I am the one who set the volume. I'm the one who set the inspiratory time. I'm the one who set the respiratory rate. I'm the one who set uh, uh, the flow. So, and FI2 and everything. So I'm the one who set everything. I don't give the patient the choice to stop the breath by himself or continue the breath. I'm the one who's setting everything. So that's what we call the set point. That's the set point. So I'm the one who set everything. What's about PRVC that we were talking about? Is that right? PRVC, you said Mahmoud was saying something right. He was saying, oh, it's like between volume and pressure. The pressure is playing a role and the volume is playing the role. So when we put patient on PRVC, I put the volume. Is that right? You are the one who put the volume. So most of the people, they think PRVC is a volume control. Me as a fellow, when I started, I thought it's a volume control because I'm the one who put the volume. Oh, I need this volume 500. Okay, you are telling the machine, hey, I need this patient to get a volume of 500.
Yeah.
However, hey, machine, you can be smart and adapt your pressure to deliver this volume according to the patient need and the patient effort. So the machine is adapting. You are not the one who set everything. You are giving space to the machine to adapt to give the volume. Okay, so let's say, for example, the first volume, the patient was doing fine, and the pressure required to deliver that volume was like 10/5 to deliver 400. Then with time, he had sepsis or septic shock. The patient will be tachypnic. Is that right?
Mhm.
The machine think that this patient is doing like the patient is going more effort.
He needs more.
So do you know what? Let's just decrease a little bit of the pressure. The machine will decrease the pressure because if the machine thinks that the patient doing a lot of effort, and that will leads to what? Leads to more failure. That's why you shouldn't just put a BRVC in a septic patient. So that's adaptive. But if it was set point, whatever happened, that volume will be delivered with the same like pressure required. Okay, so that's adaptive
But
or
in
dual.
PRVC, if we put 500 volume,
Good.
can the patient get more than 500?
Yes, he can get like 1,000. but but the machine
will change. I know
will change to make sure that you will get not less than 500. Trying
but
to.
it cannot.
You can do
more.
600.
Okay.
So you cannot put the patient in BRVC and say, hey, this patient is safe for the 6 ml per kg. If the patient get more effort, he can do more volume, but not less volume. And sometimes he can get less volume after 3. It depends on the machine and the company and the brand. Some machines will take like algorithm according to the flow. After like 3 breaths, will say, oh, I need to increase the pressure. After some of them, like time wise, after 5 seconds, 10 seconds, it will increase or decrease the pressure. Okay. And the other one is dual. And there's 7 type of targeting scheme, but we will not go over it today. We'll go over the common one. Okay. And we'll have like a 1 session just for the targeting scheme. It's like very complicated topic. Dual, which is during the same breath, the machine can switch between volume and pressure. And which, like our old machine, all of it is dual. We think that, oh, let's put patient at 6 ml per kg and he's breathing by himself, he's not in sedation. If the patient try to do more effort, the machine in the same breath, it will switch from volume control to pressure control. But you as an operator, if you don't know that, it says VC. Yes, we are controlling the volume, but it's not with a set point. You are giving more to the machine. And nowadays there is the NAVA, which is like intelligent. That's a different thing, that the machine will check the resistance, the compliance, the effort, and trying to adapt itself to make the patient comfortable at the same time is safe. All right. So when I say tag, means there is 3 things that we care about. What's the control? What's the breath sequence? And what's the targeting scheme? All right. Anything that is not obvious in here. We will talk more about it, but any questions? All right. From the Zoom land, anyone have any question? All right.
Is there a way to know that the machine is switching from volume to pressure in the dual machines? Is there a way to tell from the waves at any time?
Yes, there is a way, and we'll go over it. Yes, yes, for sure. And who's talking? Sorry.
Katabi.
Oh, okay, Katabi. All right. So how can I know which is which? So the first thing, we take it step by step, is it right? What's the control? What's the breath sequence? And then we will talk about what's the targeting scheme, okay? So looking at these waves in here, without knowing, like no one gave you that anything, like just the waves. And we talked about these waves before. How can I know? I know this is a volume control or pressure control. What's the meaning of volume control? I'm controlling the volume, is that right? And that has been like misnomer from before. Like we are controlling the flow, but it's okay. We are controlling the volume and the flow, okay? But the pressure is variable, so the pressure can change. So looking at here, is it a constant flow or not? That's a constant flow, is that right? And looking at the volume, it's a constant volume. It's the same volume between the 2 breaths. And I can say, oh, the flow is constant, the volume is constant, so the pressure is not constant. It starts like slowly up and then it's like reach to the peak. Is that right? So, oh, so what's the control in here? The volume. So I'm controlling the volume. Okay, so this is a volume control. Is it the machine triggering or the patient triggering in here? Why did you say that?
Negative.
So here the patient using PMUS, using the muscles in here and trying to breathe. The patient triggered the breath, that's totally fine, but we are the one who's controlling the volume. So that's what we call the volume control for now. Is that right? So let's look at this one. So the flow in here is decelerating. Is that right? But wait, even in pressure control, the flow is decelerating. But in here, I can see it's constant decelerating flow. There's no changes in here. It's stable, one line. Like if the patient try to take a deep breath or not, it will not change. It will be exactly the same. If the patient is triggering, is that right? but the flow is constant decelerating. Is that right? So in here, it's still volume control. The volume is the same, the flow is the same, so it's still, and the pressure is the variable. So it's still volume control. So the question to myself right now, how can I know this is a sit or that's an adaptive or that's a dual? What's the targeting scheme? And we said like, what am I the one who's setting the timing or not? So let's look at this first one. So is the time from here to here is the same from here to here? Yes, so exactly the same inspiratory time. It's it's very rare the patient will breathe by himself a full control with the same cycle. You will have some changes in your cycle. So the timing itself, it will not be exactly the same. If I see there is like changes, like if this one was constant and the second one was not constant, it's not mandatory breath. There is something else going on. That's more than enough for now to see like, oh, this is not mandatory. Dr. Megri, there is something else going on. Okay? So, but this one, we can see this is VC, CMV. What does that mean? This is volume control, continuous mandatory volume. So that's like we are giving like mandatory volume. Every breath, whatever happened, this patient will get mandatory volume. Is that right? Mandatory breath. So I'm the like I'm the one who's controlling that. Is there a VC CSV, which is like volume control, continuous spontaneous volume? Is there like a, is there something like that or not? CSV. So
CSV.
yeah, so the patient is so there is no CSV for the volume control. When you are controlling the volume, so you are telling the machine whenever this volume is delivered, cut the cycle. Is that right?
Mhm.
So there is no there is like nowadays there is no mode that has VC CSV. So if it's VC, if it's volume control, it's usually a continuous mandatory volume, or intermittent mandatory volume, but there is no spontaneous. What do you mean? Like if I'm the one who's putting this patient in volume control, I have two options. I have option that every breath is controlled with time and everything and respiratory rate, or I have the option that some breaths are controlled, some breaths are spontaneous, and what we call that intermittent mandatory ventilator, which is IMV. So the VC can have CMV or IMV. Clear or? That's right. You are not the one who choose it, but you're the one who choose like you are the one who choose, but it will not being like it will not written as VC CMV. And I will show you at the end of the lecture. So you see like you say VC. So VC, our old mechanical ventilation, the VC, our VC, it's VC IMV. We didn't have anyone VC CMV.
In the old ventilator at the St. Mary, you may see it. So now you're telling us on this, can we know from the volume scale that CMV? Because the volume is
So yeah, the volume is the same, but usually you look at the flow, the timing of the flow, and I will show you example for it. If the flow always like there is mandatory breath at the same cycle, the same timing, that's a mandatory breath. If it goes like longer and shorter, that's a spontaneous breath. The volume itself, if the volume is stable, like it's rarely that the patient will have like always exactly the same volume by himself. So if it's like changeable, that's a spontaneous. This this spontaneous could be like all the time, or it could be intermittent. If it's intermittent, that's what we call IMV.
I see.
If it's all the time, then it's pressure control, not a volume control. Yes.
My question is, there is a ventilator would be having two choice IMV or CMV, or will
Yes. And we'll go over it for sure. Not today, but we'll go over it. So this is a different patient. So what do you think? What type of variable, control variable in this patient? Why did you say pressure? You're right. Good.
Volume is different.
Good. Good. And you see like the
Decelerating.
flow itself, it's like decelerating, but you see like the decaying, like a little bit of concave changes in it.
Upward,
Yeah. So you can see like it's going in or out according to the patient lung mechanics. So in here, you said it's pressure control. Is it mandatory or spontaneous? Is the time, the inspiratory? It looks the same, is that right? So that's most probably it's BC CMV. Is that right? BC CMV. All right, let's look at this one. So it's BC or VC?
PC.
That's
The flow-
BC. Good.
The flow is not the same.
volume.
So that's why in this situation, I'm not controlling. It's not this. This is not a mandatory breath because everyone it's like changes. So in here, that's right. So in here, I have two options. Is this the first one was mandatory and the second one was spontaneous, or is the same? Both of them were spontaneous, and just the patient mechanics changes. Is that right? And that's okay to be in this point. You have to have like a longer strip to look everything and to see how it's the pattern of it. But looking at here, I can see this is a PC, continuous spontaneous ventilator. Okay, so because the timing is not the same, and stop me in here if you don't understand, because you have to understand these.
AMV, the mental, can be the same.
That's right. It could be IMV. There's 4 types, and we'll talk about them in a different lecture.
Could be CSF.
So it could be BC IMV. Yes, it could be, but I have to look at the whole picture to know if it's IMV or just a continuous spontaneous. But for like a first step definition, that's what I want you to know. Okay, it depends on the timing of itself. You got it? Any questions? Katabi, any questions? All right. So in here, I don't have to read this for you guys, but what it says that volume control, we controlling the volume and we let the pressure according to the patient lung mechanics. In pressure control, we control the pressure and we let the volume and everything else to the patient lung mechanics. Is that right? All right. So this slide, I want you guys like to put in your mind. Like as an intensivist, this slide should be like always in your mind, and like this is like you should be memorizing this more than your name. So it's the equation of motion. If you understand the equation of motion, that's like how you understand the mechanical ventilation. Okay, so we are the operators, all right? We are trying to make the patient breathe as what we want, but unfortunately, the patient he would like to breathe as he wants. Is that right? So that's why we always look at this equation. So this equation telling us that the power, the pressure of the vent plus the pressure of the muscles, which is the patient, that's the P mus and the P vent, that equal the elastic load and the resistive load. What does that mean? Like just let's make it more simple. Sorry. All right. So here we have me on mechanical ventilation, and I'm not in sedation. Is that right? I can breathe. I can do whatever I want. Is that right? I'm trying to trigger the vent, and my muscles are working. I don't have any neuromuscular problems, and I'm not in mechanical. I'm on mechanical ventilation, but I'm not sedated. I'm not in coma status. So I have my muscle power. Is that right? Normally, all of us in this room, our muscle power right now, we breathe and like we are not feeling our breathing because like there's not a lot of resistance. We are not COPD here. We're not having asthma. You are feeling normal. The atmospheric pressure and the pressure inside your lung, it's like has a good difference. So, but it's still in the first lecture we said my way of my diaphragm working and how much I need my diaphragm to work. It depends on my lung mechanics. If I have resistance, I will be breathing like trying to. If I have like bad compliance, I'll be like. Is that right?
That's right.
So that's very dependable on my
Lung
mechanics. So this is the lung mechanics in here. So here E, which that's what we have. Like we have the elastic power of the lung and the volume. The elasticity is the opposite of compliance. If I have high elasticity, means low compliance. Okay. So I have elasticity times volume. That's one power, one load. We call the elastic load. Okay. And in here, we have resistance times flow. And this is one load. Let's think about it. So, yes, our flow, when there's a dynamic, we talked about it in the first lecture. If I have resistance, so that will affect your flow. Is that right?
Mm-hmm.
But if you have like bad compliance, your lung is stiff, that will affect your volume. So this is our elastic load and our resistant load. If I have like a high resistant load, that my muscle, like, and I put you in mechanical ventilation setting that it does not go with that high resistance load, your muscles will try to work harder. And the opposite, if I give you like a very optimal volume, and everything is optimal, I will try to rest your muscles. Is that right? So that's it's very important to put this equation in your mind, and we'll talk about it. So P mus is the inspiratory pressure that by the patient. P vent is the inspiratory pressure generated by the machine. E is elastance. V is volume. R is resistance, and V dot is the flow. All right. And you say this is the elastic load and this is the resistive load. Got it? Any questions? All right. So we'll go. So talked about that. All right. So we go back to the wave scalars and the things that we look at. It should be not the numbers, the waves more than the numbers. Okay. So how can I know the load of my patient? What does that mean? What do you mean the load of your patient? Oh, we know now the load of the patient. We need to know if this is elastic load or resistive load. Means that my ventilator or my patient muscles, it is like facing a high elasticity or facing a high resistance, or it's not facing anything and it's like very good and resting. You got it? So now we know what's the tag. The tag is the volume control or pressure control. That's the control variable. And the breath sequence, if it's mandatory, if it's spontaneous, or it's intermittent mandatory. Is that right? And the targeted scheme, that's we will talk about a different lecture, we said. All right. So in here, how can I know? So in here, that's the volume control square flow. That's the constant flow. Is that right? That's volume control, constant flow. And the pressure is raising from base in here, raising up to the peak. Is that right? That's how we said this is a volume control mechanical ventilation, and the volume should be the same. So this part of like when there is like put it as a rule, if it's volume control, look at the pressure scale to know what's the mechanics. Wait, what are you saying? We said in the previous slide, if I'm controlling the volume, my muscle mechanics and lung mechanics will be playing with what? With the pressure. If I'm controlling the pressure, my muscle and lung mechanics will play with the volume. So if I'm controlling the flow and the volume, so I'm controlling it. So looking at those, it will not make a bit different. So that's why I need to look at the pressure. If I'm controlling the pressure, I need to look at the flow, okay, and the volume. All right. So in this situation in here, this part of the pressure scalar, this depends on the elasticity, and this part it depends on the resistance. And I will show you exactly if there's a high resistance how it will look like, and if there's a high elasticity how it will look like. But I cannot draw in here, is that right? Or actually I can do insert drawing. The old one. Yeah, unfortunately, I can't. Okay. I can't. There's no draw, is that right? Anyone knows? No.
Full screen, maybe on the patient monitor, maybe the one of those.
Oh, what happened? Oh, it got.
Click yes.
Just undo it.
What did you say? Like
Just to go full screen.
full screen again?
Yeah. Very top, but just scroll to the top.
Awesome. Yeah. Yes.
Is there one of them?
Yeah. So in here, oh. No, I think it is. I think you're right. Yeah, you're right. So if my elasticity is high, means that I have a patient with ARDS. So he has very low compliance. Is that right? What will happen? It will look like this. So this part, which depends on elasticity, it got higher. Okay? So that's, oh, by looking only, not calculating anything, I see, oh, this is like, this curve looks like this patient has low compliance. Let's try to do the measurement and calculate our compliance. Okay? So that's one. But if my pressure is the problem, I have a high pressure. So what will happen is this will go up and like this. All right.
Because the pressure is high to start.
That's right. If I have both of them, he has a COPD patient who had ARDS. Is that right? So what will happen is I will have high pressure and then it will go up like this. It will look like a pseudo normal. Is that right? But by looking at everything else, I can know if it's like what's exactly going on. All right. So in this situation, that's if it's square, which is rarely I see any patient that put on square.
The pseudo normal.
That's right. It's confusing. We'll go over it. So in here, that's the square. Is that right? So the flow is square. So the flow is constant. And usually when I do any calculation in any patient, I change my flow to a constant flow to get like all the numbers, my numbers will be accurate because I'm having constant flow, constant volume. The only variable is the pressure. Okay? In a decelerating flow, it's not the same. Look at here in the decelerating flow. So the elasticity is here, the resistance is here. Do you see that? And you will forget it, but if you do it every day and when you are in the ICU, you will memorize it. So if I have high pressure, what will happen is it will be like this, which we see it sometimes as like it's a regular flow, a regular volume, but it's like it looks like the vice versa, it's the opposite picture, as like you are putting it in front of the mirror. Is that right? That's give you a clue that this is a high resistance. Okay, and usually when you are decelerating, your pressure should look like a pressure control, like it's not straight, but it's like a little bit sinusoidal. So, but if you find it like this, you know you have like elasticity problem. All right, and we'll show you all of that, guys. Just like here to make it more more clear. I mean. So in here, that's the pressure control. So it's not the same when your patient on volume control square or on volume control decelerating. Okay. Now we'll look at the pressure control. In the pressure control, so we know it's pressure control because the pressure is stable and the flow is like a little bit decaying, and it's all like we know this is the pressure control. Okay. Can I know if it's like mandatory breath or spontaneous breath? I cannot know from one breath. Is that right? That's right. So in here, that's the like, let's look at the pressure. Wait, Dr. Megri, this is a pressure control. So we should not look at the pressure. What should we look at?
Look at the variable.
Look at the variable, which is the flow. In here, if I have, like usually, if I have have resistance, so what will happen is the decaying in here will go down, 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 and it will cut.
The flow will take longer.
Yeah, so because it cannot take longer because I'm the one who's controlling the time, is that right? So it will just cut before it's emptying everything. So I know that I have more resistance. Or, and I will show you pictures of these guys. Or if it's elastance, will be like this. And we have a lot of patients in ARDS, we see like their curve, if we put a pressure control like this. That's when we say this is poor compliance. This patient has poor compliance. By just looking at the vent. And usually we are not using pressure control in patient with ARDS, all right? We are controlling the volume. All right. The next.
undo. سهل لا
Click again on the
تستعمل
same.
الملوي هذاك.
No, I think that's no. I need to go to the next slide.
Click again.
Remove the whole
Yeah.
bar. By
Yeah,
that,
how do you remove it?
by that
Click
arrow.
on the
You see the arrow? Yeah, no.
click,
Yes.
click, not the arrow, the
Yes.
No, that's undoing the what I have.
Go back.
wrote.
Yeah.
Oh, here.
Just close it from
Yeah.
there.
All right. All right. So here, that's what I was drawing in here. So we are looking if the patient has a PMUS. What does that mean? What does that mean? The patient has a PMUS. Means that the patient
Move the
is
diaphragm.
moving
Yeah.
his diaphragm. Is that right?
Mhm.
And what I'm giving him is not enough for him, or maybe he has like a bad disease and he's trying to get more volume. So how can I know if this patient is trying to develop more volume than normal? Okay, so how can I know that? So because the vent, I'm the one who's controlling the vent, but I'm not the one who's controlling the volume, the patient, except if he's like paralyzed. Is that right?
Mhm.
So when I have volume control, square wave, like I have a square wave volume control, so the pressure will look like this. Is that right? The
Mhm.
black line. So if the patient trying to get more like volume, but he cannot, is that right? Because I'm controlling the volume. If it's like a real volume control, not like our volume control, a real volume control, the patient cannot take more volume because you are the one who's controlling. You're just getting 400
Mhm.
because more than 400 is bad for your lung.
Mhm.
So what will happen? The patient will try to pull down the pressure.
Mhm.
So like this red line, you see this red line,
It's trying
it's
to get
pulling
more
down.
volume.
He's trying to get it more negative
Mhm.
to get more volume. He can't, but he's trying. And some patient, you will find it like this. Oh, again. Okay. Yes, please. I'm the only one. All right. So you find it like this. And some patient, so they will start normally, and then they decide that they need more volume. It will go down like this and then goes back like this. So any drop in the pressure during volume control, I know that the patient, and it has to, like in here, if it starts at the, maybe there is no triggers, all right? It's flat. The patient did not trigger at the beginning. The machine triggered. Is that right? But at the middle of the pressure, the patient decided that, oh, no, that's not enough for me. I need more.
Mhm.
So that's when he start triggering and pulling more. So that's what in the past that we called it like a starvation for flow. That's flow starvation. So that's when here now we called it work shifting. What does that mean, work shifting? Who can try to say what's work shifting?
Work shifting because the work it goes like this. What?
You're right. Kareem, you're right.
Yeah, to switching, I mean, following the volume, but the patient tried to take over, so.
Try to shift the work from the B vent
Yeah.
to P mus. So he's shifting his work, trying to do more to prevent, to get more
To
volume.
get more volume.
Okay, so that's the PMUS. But if it's volume controlled sinusoidal, look at it. Like if it's, I mean, not sinusoidal, decelerating.
Mhm.
If it's decelerating, so that's constant, is that right? And this is decelerating. What will happen? The red line will be like this. In both way, it's pulling down, is that right? So there is activity by the patient. You might be lucky and you see the beginning in here, and then it goes up and then again, and the same thing in here, it start triggering and go up and then down again. So pulling down, that's the patient pulling the negative pressure down. He cannot be negative, is that right? He will be like, if in very bad situation, he might bring it down to negative. He will stay in the positive most of the time. So, but it is like when it
More
goes down,
negativity,
yeah, more negative than the usual pressure. And the other lines, that's what we talk about. Like if the patient has resistance, like the green is resistance load. Is that right? That's the green is resistance load. We said if resistance, it will increase at the beginning. If it's elastic, it will be like the blue one. That's exactly what I have drawn for you. Any questions? And feel free to ask. Yes.
This issue with the PMUS, do you increase the total volume or
It
sedative?
depends on your patient.
Yeah.
Is the volume is not enough for your patient? Is there a resistance? That's why the patient is trying to pull more. Is there like a bad compliance and the patient is severe ARDS and I cannot let this happen? Let's just sedate him and paralyze him for now until I fix my problem. So that's when you put your knowledge of the patient's clinical judgment and the machine itself. Sorry, Hamza, what's your question?
So the patient may have pseudo normal, and I call it normal. How could I know?
That's right.
The
It
green
depends on
from-
your pressure.
the
That's
green-
right.
The green from black.
Pressure is high. Then.
So if the pressure, like, or you reach the time that you need to calculate your resistance.
Mhm.
You do that, put the numbers on and calculate the resistance, and it's more than 10, you know that there is a resistance problem.
I see.
So this is what we call stress index. Almost the same.
No, stress index is a different scenario. And that's a different thing. We'll talk about it lecture number 5.
But I thought you are for the stress index, you look for the patient and the volume control, look for the pressure and see the patient's like needs more P, less P.
That's right. But I did not, I mean, these visions in here, these scales in here, it did not talk about stress index. Stress index is a different scenario. It's like when you put your patient in a constant flow,
Yes.
and you see at the peak inspiratory pressure, if it's like just a straight line, or if the patient start having like more deviating, that's what we call the stress index. And there is not a lot of studies about stress index, but it's one tool that you can use it with the other tools to know if your PEEP and volume is sufficient or not. But this is not our topic from today. All right. So this is then the pressure control. So in pressure control is different because our pressure is fixed. Is that right?
Yeah,
We
yeah.
cannot look at the pressure. So we look at what?
Flow.
At the
or
flow and the volume. That's right. So if I look at the flow in here, see what happened. This is the red line in here. The red line is what? It's the PMUS, the patient doing effort. So let's make it more easy. So this is, okay. All right. This is, yes, I know. Only me can edit. Cannot do it, guys. Okay, so this is normal decaying flow. How can I know if this patient is doing any effort? Okay, so if I see this like this, because normally it should be just straight like this if the patient not doing any effort. If the patient doing effort, the flow will try to increase. Is that right? Why is that? Because the patient trying to pull pressure, but he can't because we are controlling the pressure. What will happen? The flow will increase, and you will see this bump of the flow. If the patient has very poor compliance, what will happen is, so the flow, as Karim said, will decrease. Clear or not?
Yeah.
Hamza, clear or not?
Yeah. Clear.
Okay. That's inspiration, is that right? But hey, wait, we have inspiration and expiration, is that right? So the easy one in expiration, which is usually like we can look at it in both pressure and volume control. So if it's the opposite of our flow volume loop. You remember like flow volume loop from BFT? When the PFT that you see that the patient has an obstruction will be the scooping.
Yeah.
Is that right? When the patient has a restriction will be like pushed out a little bit. So that's the same, but it's the opposite picture. Okay. So when we talk about PFT, we say, oh, this is the expiration. If it's scooped like this, that's like obstruction. And if like this, like maybe this has a little bit of volume out. Okay. So it's the same in here. So the black is normal. The black is normal. Okay. So in here, it's the opposite what we're talking about in here. So in the black is normal. So how can I know if this patient is breathing against? Like he's trying to use his muscle to push out more volume out. So how can we do that? So the patient during expiration, he will trying to do more muscles effect. You see this red line? So he's trying to breathe out. more than like he needs to get more, like he's using his muscle even during expiration. Okay, got it? All right. All right. So if you look at this mechanical ventilation, is this volume control or pressure control, Saddam? Okay, good. Kareem, is this CMV, CSV, IMV? Why did you say that? It's all mandatory breaths, and the patient is not triggering. Is that right? Okay, good. So if the red line is one of the breath, and I came and asked you, hey, what happened in that breath, Hamza? What do you think happened in that breath? It should be green. The green is the normal. What do you think happened in that red line? So what's the patient's trying to do? So this is volume control. Is that what we look at the pressure?
Patient, it's the P muscles down, so he's trying to pull.
So
more
he had,
volume.
he's using more muscular
That's right.
effect. That's right. So he's using more. That's the PMUS. Got it? What's about this patient, Saddam? Mahmoud. I mean, sorry.
Resistance.
Why did you say resistance? And it's not just the peak. Let's forget about numbers, just the wave. You see how in here,
It could be both high
yeah, it went up at the beginning
and then
and then at the end. So it's not like just small at the beginning and up in the end as the elasticity. What's about this one?
this is the plateau, the elastic part.
This is like the elastic part. There's no plateau in here. We did not stop. We did not pause and anything, but this is the elastic part. So do you see like how's the difference to know this is resistive load, there is like elastic load, or there's a PMUS load? Okay. Resistance. And sometimes if the patient awake will be resistance and PMUS, which is very difficult.
Yeah, it's gonna be high on the end or gonna be.
So it will be high from the beginning and it will get higher at the end because your airway obstruction is mainly at the end. But it will be a little bit high at the beginning as well. That's a good question. Got it? What's about this patient, Kareem?
To exhale more.
So he's using his muscles to exhale more during expiration. Saddam, what's about this patient? Good. So there's a resistance, or maybe my expiratory time is short for this patient. Is that right? Usually it's not. If you are a normal patient, that should not be a big problem. But if there is an O2 beep, there is something wrong with the airways or with your mechanical ventilation settings. Is that right?
Yeah.
What's about this patient? Is the opposite of this. Elastic load. So it's like it's the lung. It's like just all of a sudden like that has high elasticity whenever the valve open.
Very good recoil.
That's right. So trying to just breathe it out because the pressure, like it's very low compliance but high elasticity. Okay. And this is a pressure control. Is that right? No, you know it's a pressure. It's a BC CMV. Is that right? What's the patient trying to do in here?
PMUS,
Yeah, people.
PMUS. Good. What's about this one? Elastic load. Good. That's elastic load. And this one? Do you know what? It could be BMUS or it could be resistive. Is that right? Or both together. Is that right? Me, if I see it, it could be both together. That's why no one can like just look at this and say this is PMUS or resistance if you don't know the patient and you look at the other waves and make sure that you look at the whole picture, not just one scale. Got it? All right, that's it. Any questions? So it will be, to be honest with you guys, like that, like I like will be smarter than me. This took me like 3 years of reading every year again and again to like reach the point of knowing the basics. So you need to like think about it every time you go to to like seeing a patient mechanical ventilation. As I told you, share the images, put the image in the group. Hey guys, like this is what's going on. What's the tag of this? What's the breath sequence of this? And if we do it multiple times and do mistakes multiple times, and I don't know all the answers, like send it to someone else who knows the answer, then we will learn. Let me give you a good app. Put in your phone, guys. Anyone can. It's called VMM. So this app, for example, so our VAR Bella Vista machine, if you put it VAC, that's what we all use, is that right? VAC, that's on the machine. So look at what's the tag of the VAC. Read this. So this is the tag downstairs, down there.
More tag. VCCMVD.
So what's that? So that's volume control.
Continuous mandatory ventilation.
That's right, continuous mandatory ventilation.
Volume,
But what's the at the end in here?
Dual maybe.
Dual. That's right. So there is the patient. If the patient has a lot of effort, it can change. So your pressure can, your volume can change to pressure. That's why. So this is, let me open it on. You know what? Let me share.
Why this company doing this for us? It should be universal.
So open your AirDrop.